Okay. All right, can everyone hear me okay?
Mm-hmm.
All right, so it's actually Wound Care 102. I just apparently forgot to change the title slide, so sorry. All right, so the goal of this one is to be able to measure and assess wounds and their surrounding tissues, have a basic understanding of some of the less common conditions and wounds that we may see, diabetic foot considerations, and then also a more in-depth understanding of the purpose of the different types of dressings that we covered last time. All right, so the sections are going to be broken down: wound assessment, types of wounds, and common dressings and their indications. So for the wound assessment, just a definition, it's any break in the protective function of the skin, loss of continuity of the epithelium with or without loss of the connective tissue. So anything from anything like a light weeping area to down to bone. What's included in our assessment, you're going to want to document the location, the measurements. They need to be actual, not references to objects frequently seen about the size of a quarter. You want to use centimeters. You want to document the wound bed assessment, the peri-wound or the tissue around the wound, the type of drainage, the amount of drainage, and if there's any odor. The wound location, you need to document the wound location for every wound, even if there's only one. The more descriptive the location, the better. You'll want to use the anatomical terms. And if multiple in the same area, you're going to want to distinguish them by proximal, distal, medial, or lateral to help keep the guessing down. Tools that you need to measure the wounds. The most common ones that you'll use are the paper disposable centimeter ruler, a cotton-tipped applicator, or DM stick. I like the DM sticks because, as you can see, it does have the measurements already on it. So it takes kind of having the guessing game of put your finger on it and then take it over to the ruler. When measuring the wound, the measurements are always taken in centimeters. They're measured using the clock system, especially when you're determining length, width, undermining, and tunneling. So 12 o'clock is always towards the patient's head and 6 o'clock is towards their feet. Length is width is from 3 to 9 or 9 to 3. And depth is going to be the straight and deepest portion of the wound. And for the anatomical position, kind of that's why I had the Da Vinci man, is the way that you're using to determine the position. And then if you have to vary the direction you're measuring the length or width because the way the wound is set, make sure you document it using the directions of the clock of how you measured it to keep it consistent for every measurement. Measuring the wound, undermining is where there's a pocket present beneath the skin along the edge of the wound, almost like a shell. This is measured typically at a range according to the clock, such as a depth of 3 centimeters from 12 to 3 o'clock. As you can see in the picture, that's the two sides of it are the undermining. Sinus tractor tunneling is an open area or tunnel that extends under the skin through tissues away from the wound bed. You can see that off to the bottom right side. And it's documented as a single location on the clock, such as 2 centimeters at 6 o'clock. Things to keep in mind with the wound bed, tissue is the issue. And the wound bed is kind of like soil in the garden. Without good soil, your garden will not grow. And the same is true with wound healing. Without a healthy wound bed, the wound will not heal. So that's where the big emphasis is, trying to establish and keep that wound bed healthy. So this is a healthy tissue that you're hoping to see. Granulation, it's soft red or pink with flesh-like bumps in the wound bed. Kind of looks like nice beefy red hamburger. Most desired wound bed tissue and suggests healthy vascular supply with a limited bioburden. Hypergranulation tissue, it is healthy tissue, don't want to typically see it. It's granulation tissue that's raised up above the wound. I think it's also commonly known as proud flesh. And you'll see it a lot when the wound is too moist because the cells get a little overexcited and start growing up. Oftentimes, you'll need to chemically burn it down or cauterize it to allow it to skin over. And then epithelium is that new, thin, fragile baby skin that is light pink and shiny. You'll typically see it coming from the edges of the wound, but sometimes, depending on the wound, especially with venous ulcers, you'll start seeing little islands of it throughout the wound. This is a picture of all of it, the granulation tissue, the beefy red hamburger, a picture of the hypergranulation coming up above, and then the epithelium coming in from the side. Some of the unhealthy tissues, fibrin slough. It can be yellow, tan, gray, green, or brown tissue. It's usually moist and can be soft, stringy, and kind of mucousy in texture. Slough may be adhered to the base of the wound or present in clumps throughout the wound bed. And that's an unhealthy tissue that will need to be removed from the wound bed, because if it stays present, it will slow the healing and also make the wound more prone to infections, kind of like Purina bacteria chow. Eschars, the dead or devitalized tissue that's hard or soft in texture. It normally is black, brown, or tan in color, may appear scab-like. Necrotic tissue and eschar are usually firmly adhered to the base of the wound and often the sides or the edges of the wound. So we have a soft eschar on the left, the dry eschar, and then you'll see the fibrin slough. And sometimes you can have kind of mixes of all of them in there too. Crusted, when a wound is covered with dried drainage, commonly referred to as scabbed over. Callus, when there's intact callus with no open area. Could be callus also covering an area of discoloration that's concerning for a wound underneath or fluid pocket. And then the big thing is if callus is left untreated, it can actually cause significant foot wounds because it acts like a rock and irritates the tissue under it. And you have unable to visualize when you cannot see all of the wound bed due to depth or tunneling. This can only be a portion of the wound that you are unable to visualize. So we have a picture of crusted, and we have a callus that you may see when there's a wound underneath it, and then kind of the unable to visualize where there's a deeper hole that you can't see down into. Other tissues that you sometimes see, not too often, you can see tendon that will be gleaming white, yellow, that is shiny and fibrous when healthy. And then when it's unhealthy, it can appear frayed and stringy. So the purple arrow is healthy tendon in this case. And then bone is typically shiny, smooth, milky white, and hard when healthy. And when unhealthy, it can have a moth-eaten appearance and be a gray to black color. And the healthy bone is in that black arrow. So how do you document the wound bed? When documenting the wound bed, you record each tissue that is present as a % of the wound. For example, this would be documented as 40% fibrin slough and about 60% granulation. You kind of do your best to guess on a scale of 100% of how much of the tissue is there. It will always vary between people a little bit of like 40 or 50 of how you would document that, but does kind of overall give you a good idea of if it's progressing towards a healthier wound bed or an unhealthier one. The wound edges, you have defined edges. This will be where there's a clear edge between the wound and the healthy intact skin. You'll see this more typically on deeper and surgical wounds. Diffuse and defined, where there's no clear edge between the wound and the surrounding skin, typically in more of the shallow superficial wounds. Epibole, also known as rolled, where the edges are rolled under or the skin extends down the edges of the wall of the wound bed to the base. This is you'll commonly see that in wounds that are undermining and in diabetic foot ulcers, but it can really occur in any type of wound. So a picture of our defined, then our diffuse undefined, where you can't really tell where wound starts and wound ends, and then a picture of the rolled edges. Epithelializing, you'll have where new epithelium cells are starting to encroach on the wound, typically occurs near the end of the healing process, and measurement should be getting smaller at this point as well. Then you have fissured, where the wound is more of a narrow cut or tear. Wound itself will look more like a fissure or crack in the skin. You're typically narrower than 1 centimeter, where you can't even get the depth stick down into them. And you'll see those most often on the feet, especially in the calluses, like on the balls of their feet, their heels, and also between the toes. So here we have our picture. And then on the right one, then you have a picture where the wound is starting to, with epithelialization on the edges. Periwound, this is the tissue surrounding the wound within 4 centimeters of the wound. So kind of that black outline that we have is what you'll document for the periwound. You have dry, and that's flaky, dry skin. You can have scarred, which is surrounding tissue scarred either from previous wounds or from the current wound healing. Erythema, you have the redness of the skin, which can be blanchable, whereas when pressure is applied, it turns white or non-blanchable. This is, if it blanches or not, is an important indicator of either infection or pressure injuries, where for pressure injuries, it will be non-blanchable. I have a picture of them. We have the dry periwound. You'll have the scarred periwound at the bottom, and then to the right, the surrounding erythema. Maceration, skin appears white and may be wrinkled. It's caused by too much exposure to moisture, by either drainage, sweat, urine, or other bodily fluids. This is important because you need to determine the cause of the excess moisture, because macerated skin is very high risk for breakdown and also infection by bacteria and fungus. Induration is an abnormal firmness of surrounding tissues. It can also appear raised from the surrounding tissue. And you have friable, it's fragile tissue that is at high risk for breakdown or is starting to break down. So for maceration, that kind of looks like he was in the cub too long. And we have our indurated where it's raised up around it. And then the fragile, friable skin where they're starting to get some breakdown, one to the right. And there's hemosiderin staining. It's a dark purple or rusty discoloration of the lower legs that's caused by chronic venous disease. This is when the vein valves fail, that regurgitated blood forces red blood cells out of the capillaries and into the tissue. And the dead red blood cells release iron that becomes stored in those tissues, results in that staining. It's indicative of chronic venous disease and typically happens over years of uncontrolled edema. And when you do control edema, it does not typically go all the way away, but it may fade down to more of a rust color over time. You have callus, the thickened layer of epidermis. This means that there is getting pressure or friction, and this will typically need to be pared down around the wound because of the cause of increased pressure. And then you also need to address the cause of the increased pressure to allow for healing. You have edema, swelling due to a collection of interstitial fluid. It can be vascular, such as lower leg edema due to venous disease, or infection, such as a red edematous toe. We have a picture of the hemosiderin staining on the left, which we've probably seen a lot in our venous people. And you have edema, like in our lymphedema leg there, and then callus on that foot wound. Ecchymosis, also known as bruising, it's a dark purple, purplish blue tissue that fades to yellow, green, gray, depending on the skin color. If new trauma is occurring to the wound and the cause needs to be investigated, determine if they're getting pressure, friction, bumping it, and then continued new trauma will slow the healing process as well. But ecchymosis you'll typically see as a normal finding, though, with fresh skin tears. Rash, temporary eruption on the skin, often raised, red, and sometimes itchy. It can be caused by a reaction to the dressing, irritation from drainage, or due to a fungal infection. Then scattered lesions, where you'll have multiple small scattered lesions around a much larger central wound. You'll typically see that a lot of times in venous-like ulcers. So we have our ecchymosis around that fresh skin tear, or rash from either dressing, looks like dressing irritation there, and then our little scattered satellite lesions around the larger central one. And drainage, it's important to know and also tell our patients that all open wounds will have some form of drainage. It's important to educate the patients because oftentimes drainage to them means that something's wrong with the wound or it's not healing or infected. I've oftentimes heard it that they're concerned it's infected because they have this open wound that they're still getting drainage from. The amount of drainage and color is also important to document as part of the assessment because a sudden increase in drainage could indicate infection as well as unusually large amount of drainage relative to the wound size. So if you have this little diabetic foot ulcer that's draining through everything you can put it on, there's probably an infection that's the cause of it. And then the color of the drainage too is important because it can indicate infection, and depending on the color, determine what specific organism is the cause of the infection as well. Or the color drainage might determine that it's a lymphatic leak rather than an infection. Our types of drainage are serous, which is thin, water-like, and it's a clear to light amber in color. It's a normal wound drainage. If there's large amounts of it, especially on a leg, I would consider it to be a lymphatic leak as the cause. Sanguinous is blood, bright red, thin, and sometimes can have clots present. It's related to trauma or active bleeding. It's only normal after initial trauma or after debridement when present on its own. Serous sanguinous is a combination of both serous and sanguinous drainage. It's thin, water-like, and ranges from pink tinge to a pale red. This is normal and a common form of wound drainage at all stages of healing. Purulent is thin or thick pus, opaque and cloudy, can be multiple different colors. The key is that it's cloudy in nature. It's not normal, and it means that there's an infection and a white blood cell response. And when taking a culture, you actually don't want, if there's purulent drainage, you don't want to culture the drainage. You just want to clean the drainage off and then culture the wound bed itself. And then green is bright green to bright blue, typically thin, and that one is actually indicative of a Pseudomonas infection. It's actually a really pretty color. I have it on our next slide too. So here's just a picture of what those types of drainage will look like, and the green one that you can see, and that is, you've never seen it, that is actually what the Pseudomonas drainage looks like. And it can also stain, the green drainage, stain the surrounding skin green too. So the amount of drainage, the wound drainage amount is considered in relationship to the size of the wound. Your normal amounts are scant, small, and moderate. Your abnormal amounts where you want to consider an infection, lymphatic leak, or other non-wound fluid is if you're getting large or copious amounts. Odor is determined only after the wound is cleansed, not by the odor coming from the dressing, the wound vac, or prior to cleansing with saline. You'll document it as none, mild, where your nose needs to be close to smell the wound, or smell the odor. Strong, you can smell it through the entire room. Oftentimes, on those people, the smell will greet you first. With those people, having fresh coffee grounds around can also help neutralize the smell to some extent. And then foul, it's similar to rotting flesh, kind of like roadkill in the summer. And then if it's an anaerobic bacteria, it will actually tend to have a putrid yet sweet smell to it, which is a kind of unique smell. So kind of an example of everything all put together of how you would document it for this foot ulcer would be a left plantar, first met head, and it measures 0.5 by 0.5 centimeters by 0.1. Our base for that one would be 100% granulation since it's all that red beefy hamburger. The edges are defined because you can clearly see where they start. Our periwound, we have the dry skin around it and some callousing. And for that one, you would guess a normal amount of drainage would just be a small amount of serous sanguinous, and I would suspect no odor, but can't do too much for that for the picture. All right, any questions so far on measuring or assessment? So some types of wounds that we didn't cover, or we did cover the last one, but we're going to go a little more in depth in today. Went through the slide for the pressure ulcer. We're just going to go more through the staging today, but biggest thing, once it's a stage, always a stage, unless it deteriorates. Yeah, oh, and the biggest thing is pressure management to keep in mind. So our stage 1 for pressure ulcer is going to be non-blanchable erythema of intact skin, so there's no opening or no blistering. Stage 2 is going to be a partial thickness skin loss without exposed dermis. They also present as a blister. With this one, when documenting it, there would be no fibrin slough at that stage. But a stage 3 will have full thickness skin loss, where you'll see adipose, granulation tissue, and rolled edges are often present. Slough and scar may be visible as well for this one. Stage 4 is full thickness skin and tissue loss. You'll have exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in this ulcer. Slough and eschar may be visible. Rolling and undermining and tunneling often are occurring as well. You have unstageable, where there is full thickness skin and tissue loss, but it's obscured. And you cannot determine the extent of the tissue damage because a lot of times you'll have a fibrin or slough covering to it. That once that were to be debrided, you would probably have some bone, muscle, or tendon visible. Deep tissue pressure injury. It's a persistent, non-blanchable, deep red, maroon, or purple discoloration. You'll see that on intact or non-intact skin with a localized area of persistent, non-blanchable, deep red, maroon, purple discoloration, or epidermal separation, revealing a dark wound bed or blood-filled blister. Pain and temperature will often precede skin color changes. And the deep tissue injury is kind of like a pyramid. What you're seeing is the tip of the pyramid, and then it gets larger a lot of times in a cone shape beneath it. And just here's a little guide of the different stages, or stage 1, or stage 2, 3, 4, the example of an unstageable, and then kind of what's going on with a deep tissue injury underneath the surface. Diabetic foot ulcers, they're, by their name, any open wound on a foot of a diabetic, regardless of cause. They're greater risk to have, diabetes are greater risk to have ulcers on their feet due to the loss of protective sensation, also known as neuropathy. 15% of diabetics will get a foot ulcer in their lifetime, and those who get a foot ulcer, 14 to 24, will require some form of amputation. And they pretty expensive to healthcare every year. They can start as a discoloration under a callus. They're often present over bony prominences or areas of increased pressure. They tend to have an even wound margin with round punched out lesion with a deep wound bed. Callus rim is common. Oftentimes they are non-painful to the neuropathy, and some people only notice them by the drainage on their socks. Common causes are neuropathy, the 3 different forms of it, oftentimes occurring together or sometimes just separate. You have the motor, which causes an imbalance between flexion and extension of the foot, resulting in different deformities. Then you have autonomic, results in diminished sweating, and the tissues becoming drier and more likely to crack and break down. Then you have sensory, and this is what allows the other forms to develop into wounds because they lose the protective sensation of their foot where they can't feel pressure if they stepped on anything, or a blister forming, or even an open wound at all. And then another causes are ill-fitting or lack of footwear, like people walking around barefoot at home, stepping on something, or shoes that are too small or too big and they're sliding around. Burns from bath water and heaters. That one happens more often than you would like to think, especially from heating grates. And then improper nail care, where they're cutting down, where they're trimming their nails and then cut down into their actual nail. Biggest thing for treatment, offload the area. They're difficult to heal with repeated trauma and pressure, and that's the biggest influence on healing. To manage the diabetes, try and get an A1C goal of 7. You're going to want to debride callus and non-viable tissue. The dressings that you'll most frequently use are absorbent and typically an antimicrobial, a lot of times an iodine-based dressing. Depending on how bad the ulcer is, there's a potential for hyperbaric oxygen therapy, and as always, there's always a risk for amputation for those people. The patient education with it, when they have it and after and ongoing, is that they need to do daily foot checks to look for areas of callus, discolorations, or open ulcerations. They are to never walk barefoot or in a sock. A sock is still considered barefoot because it doesn't provide any protection. Proper nail care for them. And then it's recommended that they wear white or light colored socks. And this is because if they do have anything that opens, when they take their sock off, they would see some drainage or discoloration on their sock. So with the diabetic foot, there's some assessments that you're going to want to do for them. You have your neuropathic foot screening, which is just a monofilament exam that tests 10 points on each foot for sensation. And I have the pattern off to the right that you'll typically do. And then you would document it as, like if they could only feel 2 of the 10 points, you would do it 2 out of 10, with how you would rate the score. You're going to want to check for pedal pulses. With this one though, a palpable pedal pulse is not always an indicator of good blood flow, but a lack of a palpable pulse is. I think it's estimated that about 80% of people with arterial insufficiency will still have a palpable pulse. You're going to want to examine their hair patterns, because if there's hair on the toes, they most likely do have good blood flow. But a good rule of thumb is where the hair pattern stops, the blood flow typically will decrease there, whether it's on the toes, the foot, or the lower leg. You're going to want to look at the foot temperature and color. If the foot is cool and pale, you're going to want to consider blood flow. If the foot is hot, red, or pink, and there's no open sores to it, you want to consider a possibility of an active Charcot foot. And then you want to look at and document their foot deformities and or prior amputations. The deformity and prior amputations is kind of going to be a predictor of what areas are concerned for breakdown in the future. So some considerations for them, you're going to want to ensure that they have proper fitting footwear. They may need to have footwear pressure mapped first prior to transitioning into that, especially if they have a history of deformities or frequent ulcerations. And if they do have deformities, they're most likely going to need custom footwear. But the good thing is, especially if they're diabetic, this is covered through Medicare and they receive 1 pair of shoes a year with 4 sets of custom orthotics. And when they do transition into new footwear, they will need a break-in period. And the big thing with that, and to educate them on the break-in periods, not to break in the shoe, but to break in the foot to the footwear. And it's typically done in over the course of a couple weeks, with a time frame that starts off pretty short and gets longer and longer. And then you want to assess the patient's ability to perform foot checks. Some of them may require assistive devices such as mirrors on a stick or a mirror on the floor that will allow them, or train family members to help them assess their feet. And if they've had an ulceration and or deformities, they should, in ideal situation, wear footwear even when in the shower. They'll have the shower shoe, which is oftentimes either just a slide sandal or croc. But it's because even just a little bit of time standing on the hard floor in their shower can start to cause some breakdown. So with diabetics and also some people with neuropathy, you can get the Charcot deformity. It's also known as the rocker bottom foot. Again, most commonly seen in diabetics. With people with neuropathy, have the same conditions that will cause it as well. But for the cause of it, there's not one definitive cause, but rather multiple different potential causes, such as an untreated sprain, broken bone in foot that's not treated, bone loss. And what makes That's so problematic is that the loss in the protective sensation results in them not being able to feel the cause or the changes happening. They wouldn't know that they had a broken bone and just keep walking. The signs that you're going to look for, suspect with that's going on, is when the foot is red, hot, and swollen, that may or may not be misshapen depending on how early it is caught, or if they haven't had it before. And the hallmark is you'll notice the temperature is going to be different between both feet as well. On the bottom, we have a picture of the normal foot with the arch in there, and then the collapsed Charcot. And then the foot to the right is a pretty extreme one, but nonetheless, it's one that you'll see. So the treatment for those is you need to take weight off the foot, and that's typically for them being non-weight bearing for a period of time. You're going to treat the bones oftentimes with a total contact cast or an offloading boot. Total contact cast is the one that's at the bottom, and that's designed to conform to the foot, keep the bones where they're at, and also take, if they do stand on their foot, take the pressure from the bottom of their foot and transfer it up through the tibia. And that's actually also used for healing diabetic foot wounds too. So, but that's typically about a 6 weeks of offloading and casting for them. And to prevent future breakdown and fractures, they're going to need some custom footwear, and depending on how severe it was, sometimes for a short time, a crow walker, which is that big one, the big black one there, or at least for a few months to help it stabilize. And there are surgical reconstructive surgeries as well too that can be done, but are pretty intensive ones that require significant aftercare. And then some precautions with them is, due to that deformity, they will be much more likely to develop ulcers in the future, and they are always at risk for it becoming active again and for further foot deformities occurring. One that's not so common, but almost seems like it's becoming a little more common, is Pyoderma Gangrenosum, or just typically hear it called just Pyoderma. It's an uncommon ulcerative cutaneous condition of uncertain etiology. It's associated with systematic disease in at least 50% of the people who have it. It affects males and females of any age, but is more common in people over 50. Some common conditions that are associated with it are inflammatory bowel diseases, such as ulcerative colitis and Crohn's, rheumatoid arthritis, and leukemias. So for this, its presentation, it's characterized by a full thickness ulcer with blue undermined borders, and by pathergy, which is the appearance of new lesions after local trauma, or when it's debrided, the wound becomes larger as well. It may start as a small blister or pustule following a slight injury, and it can quickly break down, and they tend to be very painful. For them to diagnose, they are actually a diagnosis of exclusion, and you'll need a biopsy to rule out other conditions. The typical treatments are topical steroids to the wound itself, tacrolimus ointment also to the wound. You're going to want to avoid debridement during the active phase because it will actually make the wound larger. Sometimes you'll see use of oral doxycycline because it's an anti-inflammatory antibiotic, and for some of the larger lesions, you'll actually do oral steroids as well. So some considerations with this during dressing changes is you're going to want to avoid causing trauma to the wound with dressing removal and with cleansing. And then if topical medications are ordered, they do go directly onto the wound, including the steroids, where most of the time in other wounds, your steroids are on the periwound. And with the topical medications, they do typically require frequent application, oftentimes up to 2 times per day. And osteomyelitis, or bone infection. Times to think about that there might be a bone infection present are when you have a red, swollen, bulbous toe with a wound, more like a sausage toe in appearance, kind of like the one in the picture. And you have a diabetic foot ulcer that fails to heal after 6 weeks of appropriate wound care and offloading. You see bone in the wound bed, where the wound probes to bone, when you have exposed hardware, you have a recurrent wound, especially over bony prominence, or you have gangrene. Diagnostics for osteo are ESR, CRP, where one or both of those will be elevated. But if a patient has an inflammatory condition, this may be elevated at their baseline as well. You also need an X-ray that will show up if an infection has been present for over 2 weeks and with significant bone loss or destruction. The MRI is the most useful. It can detect it much earlier than an X-ray, but with that, the X-ray has to be done prior to the MRI, no matter what, for insurance to cover the MRI. So at that point, if your ESR and CRP were elevated, the X-ray was negative, and it kind of meets some of the other qualifications for where you would consider osteo, that's when you would order the MRI and go with the MRI or see the MRI done. Also, sometimes there's a 3-phase bone scan or a tagged white blood cell scan, and that's useful for patients who are unable to have an MRI due to pacemakers and other or metal fragments. A treatment, they're going to have at least 6 weeks of antibiotics, oral or IV. Can be amputation, surgical debridement of the infected bone, and in diabetic foot ulcers, it can be hyperbaric therapy. What the patients need to know with this are that they need to complete the entire course of the antibiotics without a lapse in taking it. Or if they do have a lapse more than a day or two, the whole course will most likely need to be restarted. Probiotics are encouraged for them with long-term use of oral antibiotics and for 1 month after they're done. And they need to notify of any side effects prior to stopping their antibiotics, so that way the antibiotic can be changed. And the big thing is bone infection does not necessarily mean amputation for them, but it does put them at a higher risk, and that they'll also need to be prepared to have labs drawn every 2 weeks while on the antibiotics and for 2 weeks after the antibiotics. So this is just any questions on the types of wounds? Okay. So this next one, we went over how to apply the different dressings last time. This is just going to be why you would choose those dressings. So the saline, the wet to dry, it does a mechanical debridement and it fills dead space. Our advantages are it's easy to apply, inexpensive. Disadvantages to this are it can damage granulation tissue on removal, may dry out the wound, and it does require daily to twice daily dressing changes. Non-adherent contact layer used to prevent dressing adhesion to the wound bed or graft, used on painful, friable, or fragile or bleeding wounds. You can use it on skin tears, use it for securing grafts, and you use it to protect tendon and bone when using negative pressure wound therapy or wound vacs. The advantages are it helps prevent trauma to the wound bed during dressing changes, protects bone and tendon. Its disadvantages, it's not appropriate for wounds with thick drainage because it will trap it underneath. Hydrocolloid or duoderms, used for providing water-resistant protective barrier, reducing pain, minimally exudating wounds, and also I like to use them too. Another is for outlining the periwound when applying a wound vac. Some advantage is it's good at providing a layer of protection and reducing friction. It encourages autolytic debridement. Disadvantages with are they're not for moderate to heavily draining wounds. It's not to be used on infected wounds. It can cause damage to fragile skin, and it's not to be used to cover wounds with sinus tracts. Transparent dressings or tegaderms used for water-resistant protective barrier, allowing wound visualization, protecting skin from friction, and some also securing primary dressings. The disadvantages are it may tear fragile skin upon removal. It's inappropriate for exudating or infected wounds as the main dressing. It also may cause maceration because it does trap moisture. And it's not to be used on wounds, again, that are undermining or with sinus tracts. Packing is used for tunnels or cavities, filling in space while supporting management of drainage, and encourages healing from the bottom up. The disadvantages are that if it's not secured, it can become lost in the wound, and it does need to be changed frequently. So this one was not covered in the last one, so for using it, you choose the appropriate size of the packing. It can be from 1/4 inch all the way up to 4-inch roll of Curlex in width. And if indicated, you can apply hydrogel, iodine, or other antimicrobial liquid, such as Bosch, wound cleanser, acetic acid, or Dakins. You're going to want to pack it loosely into the tunnel with the soft end of the cotton-tipped applicator. You don't want to overfill it. It's more like fluffing it in there. And then the big thing is you're going to want to leave a tail hanging out of the wound and then tape it to intact skin to prevent it from getting lost, especially on some of the coccyx deeper ones that sometimes dressing may fall out to the toilet, in that people don't always know. I have seen it where they thought it fell out, where it really got sucked into the wound, and then they get a big infection because it gets lost in there. And then you're going to always cover them with some sort of secondary absorbative dressing. You're changed about 1 to 2 times per day, depending on if you're using an antimicrobial one. You can sometimes get away with changing them 3 times a week. That's typical with some of the iodine, some of the antimicrobial packing ribbons, such as your Aquacel AG, your Cutamed, or your Hydrofera Blue ropes. Your foam dressing, those are for moderate to heavy exudating wounds and can be primary or secondary dressings. They're used to maintain a moist wound environment and also protecting the wound from trauma. The disadvantage is they may macerate the wound edge if the dressing becomes saturated, and can also sometimes stick to the wound bed. Absorbent dressings used as a primary or secondary dressing can handle large amounts of drainage, and it can protect the wound from trauma as well. The disadvantages are it may macerate the wound edge if it becomes saturated. The calcium alginates and hydrofibers, they're used because they're highly absorbative. They can fill in dead space, used for packing, and they control heavy drainage. The disadvantages are that they can dehydrate the wound bed because they do absorb so much drainage. They're not appropriate for dry wounds or wounds with eschar. And depending on the type of alginate or hydrofiber you use, it can macerate the periwound if placed over intact skin. Collagen dressings, powders, or gels, they're used for chronic wounds. They're used to regulate the microenvironment of the wound bed. The disadvantages are they're not appropriate for significantly necrotic or infected wounds. And they work by kind of providing collagen in the framework to help granulation and healing. Hydrogel wound fillers and gels. They're used on dry wounds with slough for low exudate levels, used to hydrate dressings and to hydrate wound base. They can soothe and reduce pain. They provide a moist wound environment and encourage autolytic debridement. The disadvantages are they can cause wound macerations, and they do have poor anti-infective properties. You don't want to use those when you're trying to keep a wound free from infection. The iodine dressings, they come in a foam, paste, or gel. They lower the pH, they're antimicrobial, they work to remove slough and absorb exudate, and a lot of those have a progressive release of the iodine with exposure to drainage. The disadvantages, they're contraindicated in people who are sensitive to iodine. They can cause a transient stinging or burning sensation, and all of them do require secondary dressing. Hydrofera Blue, it comes in the original foam, which you need to rehydrate, the ready foam, and the packing foam. You use that, use that for its antibacterial, and it's antibacterial by the 2 dyes that are in it. It debrides with removal. It reduces biofilm, and it also has antifungal properties. Some of the disadvantages are that if you're using the original, it can dry out the wound. Same thing as its advantage is a disadvantage. It can also stick to the wound and be painful for removal for some people. And a thing to know with it, even though the manufacturer claims it won't stain the skin or the drainage, it can sometimes stain the surrounding skin purple or blue. Silver dressings come in gels, foams, alginate, non-adherent mesh, pretty much everything. They're designated by the AG in the name and oftentimes have a gray appearance. They're used for wounds with symptoms of infection or a concern of infection as primary concern. Disadvantage, the bacterial resistance to silver is increasing. What make it work against being antibacterial can also affect good tissue in the same way. Can cause silver toxicity if used on extensive wounds or in pediatrics. And it is also falling out of favor with the rise of newer antimicrobial dressings with fewer side effects, and it cannot be used for more than 2 weeks at a time. Medical honey comes in gels and hydrocolloids. It's used to promote a moist environment. It's antibacterial and it promotes autolytic debridement. The disadvantages are it can cause maceration. Sometimes it's painful. And even though there's supposed to be no venom in it, it's recommended to avoid use in patients with bee sting allergies though. Okay, so just a quick review. For the wound assessment, big things are always document the location, always measure in centimeters, length is always from head to toe. If it's not up to skin surface, always check the base for depth and undermining, and don't forget to document the wound base and peri-wound edges. Wound types and considerations for diabetic foot ulcers, offloading is key. Charcot deformity, 6 to 8 weeks of immobilization and strict offloading. Pyoderma, avoid trauma with cleansing. Pressure ulcers, offloading is key. Once a stage, always a stage unless it worsens. And osteomyelitis, at least 6 weeks of continuous antibiotics with no lapse in coverage. Kind of dressing considerations, I think I had this on here last time, is if it's wet, dry it out. If it's dry, add moisture. Wounds are like Goldilocks. They don't want to be too wet or too dry. And the goal is to find moisture balance and correct the underlying condition that caused the wound to allow for healing. Any questions? All right, I know it's a lot of information kind of all at once, but if you have questions or anything in the future, just always let me know.
Christina, this is Christy.
Yes.
I sent you a chat question, but you may not see that. Anyway.
No, sorry.
I thought a couple of years ago they changed that for a stage 2, that could be, I guess, D-staged, what they call D-staged or healed, but a stage 3 or 4 was always stage 3 or 4.
So if the stage 2, you're not going to want to, bring it down, back, change. So as it's healing and it gets to where it's just the red in the skin, it's not going to change back to a stage 1.
Okay, but like I know a stage 3 or 4 healed is still considered a stage 3 or 4. Mm-hmm. But a stage 2 could be completely healed and not still be considered a stage 2, even though it's healed, right?
Yes, that's correct.
Okay. And then a blister, that's not open, would you consider that a stage 2 or?
For the pressure ulcers, that would be the stage 2.
Okay. Thank you.
You're welcome. And if no one else has any questions, I think that's the end of the presentation, but if you do, just let me know. Thank you, everyone.
Thank you. Good information.
Thanks.
Yes, thank you, Christina.
You're welcome.
Can you send us out a copy of your PowerPoint?
I think so.
Please.
Yeah, it'd be good to have that in the reference.
Yeah, so I don't know how to send it out. I might need to create like a Google Drive because it is fairly large. I think it's 112 megabytes.
Oh, okay.
But I'll see if I can maybe zip it on my computer to send it out. I'll have to do a little digging on that.
Thank you.
You're welcome.
Bye-bye.